Afternoon. Our first lecture today is going to be on the trauma team from pre-hospital through the emergency department, but it really involves the trauma team through the resuscitative phase of care. I might begin by saying the Society of Trauma Nurses has a library full of topics of different aspects of trauma and lectures. So two of those are going to be taught today. I'm hoping we can go through the whole lecture series over the course of the next few trauma grant rounds, just to give us a good broad-based understanding of all the scope of trauma. So what we want to do today is talk about the trauma team from the pre-hospital through the emergency department and how we assess those priorities as a team. We'll talk about some emergent interventions for life-threatening injuries, those things we have to stop and address immediately. And we'll talk about some evidence-based practice changes and controversies that have happened in the pre-hospital setting and the emergency department setting over the last few years. So again, the underlying principles for trauma are we want to maintain readiness and hypervigilance and consistent organization and clear communication between the team to improve outcomes. By hypervigilance, we mean this. We presume every patient coming in is dying until we prove they're not, as opposed to presuming every patient is fine and being reactive and waiting until their blood pressure drops or we see massive hemorrhage before we address those issues. Practice makes perfect. Obviously with teams, if you play athletics or sports, teams are practicing all the time, but we try to do that. And one way we do that is with every trauma, even if it's a level 2 trauma or we think it's a low level injury, if we function the way we ought to as a team, then when patients come in who are critically ill, it makes it much easier for us to take care of the patient. Again, the successful trauma resuscitation is only as good as its team. Therefore, we have to work together and communicate together like a team. And then again, the importance of team leadership in trauma resuscitations. And again, as we talk about this in the pre-hospital setting, it may be the lead paramedic or the lead first responder or EMT. In the trauma bay, it may start out being the emergency medicine physician and move to the trauma surgeon. As we move up to the ICU, that may change as we go along, and we'll talk about how that changes. So again, in the EMS setting, they'll do a primary assessment. They'll get some vital signs and some basic history, frequently about the mechanism of injury, as well as does the patient have any pre-existing medical issues. They'll do a secondary survey to identify injuries and treat them as accordingly. We'll talk about scene times. We try to keep this short. EMS has a very few minutes to decide, does this patient need to be taken to a trauma center or can they go to the local hospital? If we call the trauma center, do we need to activate them and how do we do that? So we'll talk about general trauma alert criteria. Every hospital has different specific criteria. Although the American College of Surgeons Committee on Trauma, who sets the standards for trauma centers, has some certain criteria that need to be on there. We'll talk about scene time. How long should the paramedics and EMS providers be on the scene before they start moving the patient to the transporting them to the hospital? Under what circumstances will a pre-hospital team decide they need to bypass a closer hospital to get to a trauma center? And then we'll talk about vascular access and fluid administration. It's how that's changed and some of the controversies over the last 10 to 20 years. Obviously, airway starts with A, so we always want to worry about that. But in the trauma patient, we want to pay particular attention to any consideration for whether they have a cervical spine injury. Here you see they're doing a jaw thrust, but we always try to maintain spinal stabilization when we're managing the airway. When we have a patient with suspected spinal injury, things have changed a little bit, and again, this gets a little controversial. Now, if we suspect a spinal injury, we obviously place them in a collar and a backboard. If they've got an altered mental status, we suspect spinal injury. If they've got any neck pain or tenderness, we do the same. If they've got any paresthesias, tingling, numbness, weakness in one of the extremities, we obviously want to suspect that. And if they have major distracting injuries, so if they have an obvious femur fracture, even if they don't have pain in the cervical spine, we place a collar. What has changed over the last few years is when a patient has been on a backboard for a prolonged period of time, you can have some complications. No patient has ever gotten a complication from a cervical collar or a backboard placed by EMS. What happens is if the patient comes into the hospital and spends hours on the backboard waiting to be quote unquote cleared and waiting for x-rays, when they've been on that backboard for a prolonged period of time, they can get breakdown on the back of the skin on their back. In the elderly population, that can be as early as 2 hours. So when we get a patient who's been immobilized, we want to early on in the resuscitation, take them off the backboard so they're on the mattress. Now, on the stretcher and on the mattress on the stretcher. So there's not the risk of pressure injury on the back. We continue to maintain them in log roll precautions until we've radiologically or clinically determined that they don't have a thoracolumbar injury. Okay, I hope you can see that. I realize it's busy. This is the way we divide up here at Lutheran Hospital our trauma team activation. In the left column, you'll see full trauma team, and I apologize for the size of that, of the writing. What we broke up the trauma activation is to airway and breathing issues. Again, A, B, C, D, E. So airway and breathing issues. If someone has been intubated in the field, if there's been an unsuccessful attempt to intubate them in the field, if they have a rescue airway, so an iGel or an LMA or a combi tube or a King airway, any of those, or if we're unable to secure an airway or ventilate a patient. Those are obviously things that need the entire trauma team there. That's the airway and breathing. C for circulation. It's a single blood pressure based on age. And again, there's some data that shows even with a single low blood pressure in the pre-hospital setting, even if all subsequent blood pressures are higher, those patients are at higher risk for having some significant bleeding. Anybody who's received blood products in the pre-hospital setting, this usually happens. Many aeromedical services, including our own Lutheran Air, are able to give blood in the field. So if we give, if they're getting blood in the pre-hospital setting, those will also be the highest level of trauma activation. And if a tourniquet's been placed, because presumably there's been a lot of hemorrhage there, so even with the tourniquet placed, that signifies some circulatory issues in the pre-hospital setting. They'll be a level 1. For the disability, which are really neurologic, it's someone whose Glasgow coma score is less than 13, or if they have paralysis or a suspected spinal cord injury. There are a few anatomic criteria that give the highest level of activation. Bilateral femur fractures, and obviously that's because you can bleed a large amount, up to 1,500 cc's into each thigh, so that'd be a 3-liter blood loss. Anyone with a mangled or crushed extremity with some vascular compromise, or anybody with an amputation proximal to the wrist or ankles. For penetrating mechanism, obviously those patients would need to go to the operating room early, so that's why they're also level 1 activations. For penetrating trauma mechanisms, anyone with penetrating trauma to the head, the neck, the chest, the abdomen, or on the extremities proximal to the knee or elbow. Obviously, those patients are going to be significantly injured and are going to likely require a quick trip to the operating room. Burn patients greater than 30%, we put those on to get the trauma team down there. We're blessed here to have the burn center located in the same facility. So we will usually begin that resuscitation, make sure there are no concomitant traumatic injuries, and then the burn team gets involved to manage those patients further. And then you'll see provider request. Any patient who doesn't meet the above criteria, but the ED physician or trauma surgeon feels they really need to be activated, we can do that. In the next column, the level 2 trauma activation criteria. These are some physiologic criteria, which include persistent tachycardia or respiratory rate, multiple orthopedic fractures, not long bone fractures, but multiple other fractures, and then the mechanism of injuries. So falls from different heights, anybody that falls on anticoagulation, high-speed auto versus pedestrian, high-speed motorcycle or ATV crashes, motor vehicles where there's intrusion in the vehicle of more than 12 inches, any patient ejected from the automobile, anybody who is in an automobile where a person in that same vehicle is dead, because that's all those presumed higher mechanism of injury and higher transfer forces. Burn and electrical injuries are there as well, particularly electrical injuries and burns greater than 10%. And then we have some special patient populations, pregnant patients who are presumed to be greater than 20 weeks, any child who's been unrestrained or improperly restrained and they're less than 13, and then patients arriving by aeromedical transport. So that's the way we kind of divide up our traumas here, and that's consistent with the national guidelines as well. What are some of the challenges to airway and immobilization? Well, obviously, as you see in this picture, an elderly patient with osteoporosis is kind of hunched over. That collar is put on. That doesn't bring them back. So sometimes when a patient is, elderly patient is on a collar like that, we have to put some pillows or blankets behind the neck to keep them in their neutral position, which is not necessarily what their neutral position was when they were younger. So obviously airway starts with the ABCs. We want to make sure that they've got airway is patent and they've got spontaneous breathing. And that's our biggest priority. We say all trauma patients need oxygen until proven otherwise, usually with a pulse ox. Just remember that the problem with oxygen in certain populations, if you have a head injury and get hypoxia for even as little as a few minutes, your mortality and your neurologic outcome are worse, even with brief periods of time. If you're a pregnant patient, by the time you get hypoxic, maternal blood has been shunted from the uterus, so that puts the baby at risk. So that's why we say don't wait until someone gets hypoxic till you start oxygen. We use it until we prove otherwise with a pulse ox or other evaluation. Here are some of the adjuncts to airways. You've got the King airway, the combi tube, and the LMA. I think most pre-hospital providers in this area use the iGel, which is very similar to an IMA, or to the LMA. Just fire that over here. This is it here. It looks very much like the LMA, but we'll put it on the field. If we know the medics are coming in with this, we will prepare to try to intubate them or come up with a more secure airway before we leave the trauma bay. One thing about the iGel or the LMA is if the patient vomits, their airway is not protected. So that's why we want to address that early. So there's been some different reporting and data about pre-hospital intubation. For years, a number of studies said that it improves outcome in patients with severe head injury and with multiple injuries. We've also had a number of patients that showed there's no change in outcome. And then most recently, we've had a large number of patients that show it actually worsens outcome. These are multiple studies in very large centers with very large pre-hospital populations. Some of this has been thought that during the process of intubating the patient, they might get hypoxic. Another challenge, in addition to hypoxia and deteriorating outcomes or making outcomes worse, is changes in CO2. So if your PCO2 gets too high or gets too low, both of those can cause problems. Again, that might be from over-ventilating the patient prior to intubation or them getting underventilated while they're in the process of intubation. So that's mixed. Many hospital protocols say that if the Glasgow coma score is less than 8 and you can't maintain an airway otherwise, they'll get intubated. We try in all of these cases to use pulse oximetry and end-tidal CO2 and maintain end-tidal CO2 in the normal range. The other challenge you'll have with patients with airways, if the airway is questionable and they're coming by air, frequently they get intubated before the aircraft takes off from the seat just because of the challenges of trying to intubate someone in a moving aircraft. So we always recommend bag valve mask. I know someone's going to look at that and realize that's not exactly the way to do it. You've got to get your third, fourth, and fifth fingers under the jaw to lift it up and create a seal so you get a good seal. But bag valve mask, I think, is sometimes an underutilized adjunct in the pre-hospital setting. So that's airway and breathing. Let's talk quickly about circulation. Hemorrhage control, there are two proven effective techniques for hemorrhage control. The one that I think is excellent and sometimes underutilized is direct pressure. The other one is tourniquets. And if you know that after the Boston Marathon bombing, of the 27 tourniquets, patients that came in with tourniquets on from loss of limb, 24 were not properly functioning. Based on that, there was a group up in Connecticut, it was called the Hartford Consensus, that talked about how we can improve this so tourniquets are better. The Trauma Combat Casualty Care, or TCCC group, with the military came up with tourniquets and came up with some recommendations. I think everyone has heard of the Stop the Bleed campaign, which teaches lay people and what they call the immediate responders of mass disasters to apply tourniquets. And in many places now, if you go out in the public next to the AED device, frequently there's a Stop the Bleed kit. Unproven techniques, just the way elevating the limb doesn't help, pressure points don't help, and please don't put ice on a wound to think it's going to stop the bleeding. So here's the tourniquets. These are the Special Operations Force Tactical Tourniquet, or the Trauma Combat Casualty Care team. The important thing, and I'll show it right up here with the tourniquet, is you pull this around the leg. You got to get it as tight as you can. It's got to hurt the patient. They should say at least ouch. After that is this device here is the windlass, and you crank this as hard as you can before you lock it into place. Once it's locked into place, frequently we put the time on it. We have to note the time it went on, and usually in the pre-hospital notification, as I mentioned earlier, if we know that the tourniquet's in place, we'll get a level 1 trauma activation. So indications for tourniquet: hemorrhage that you can't control with direct pressure. A traumatic amputation is another one. Sometimes if someone is in a distant environment, or in what we call sometimes the austere environment, we'll have to put one on because it's hard to hold direct pressure as you're trying to carry someone out of a woods, or if they're entrapped, or if you're in a tactical environment with law enforcement where you can't evacuate the patient quickly. There are no contraindications to applying a tourniquet, assuming that you have tried direct pressure and it's failed, or you can't based on your austere environment. But again, we want to quickly evaluate that. And if we don't think the tourniquet needs to be on once they get to the hospital after evaluating them, we'll take it off then. That's tourniquet safety. Obviously this, sorry for the graphics, but obviously this patient needed a tourniquet. They've got bilateral amputations, and do I have? Right there, that 21:25, that's the time that the tourniquet was placed. Again, with these homemade tourniquets, you'll see that wood stick functions as the windlass on the made tourniquet here, and that's twisted to tighten things down. Now we talk about 2 large bore IVs. Again, historically, and back a number of years ago when I was a paramedic, you put 2 large bore IVs, and large bore, by the way, is a 14 gauge or a 16 gauge. I think sometimes we think large bore is 18 gauge, but 14 or 16 gauge, and we will give them 2 liters of fluid. Now we're a little bit more selective with the fluid. They'll put an 18 gauge in. Again, if they're hypotensive, 18 is not going to be big enough. And then we'll put normal saline or lactated ringers. If you can't get a second IV in, we'll consider the intraosseous as well. Many protocols now, if your blood pressure is down below 100 or your heart rate's above 120, we'll start with a 500 cc bolus. So previously we'd give 2 liters, and if you took a little long to get to the hospital, you just keep hanging fluid. And frequently patients came to the hospital already having received 2 or 3 liters of fluid. We've kind of backed off on that now. There's a fair amount of evidence that shows that a large volume of fluid, which doesn't carry oxygen, obviously, and also may cause breakdown of the clot by increasing blood pressure. So we try to give just enough fluid to keep their systolic blood pressure above 90. That's the intraosseous infusion, and yeah, just give me the gun. Andrew's bringing some things over here. So these are pointed like this. Here's the intraosseous needle. You hook this up to this, you pull a trigger, and it actually drills it right into the proximal tibia, or sometimes the humeral head as needed. These are available in the emergency department. They're available on most paramedic units, in the advanced life support units in the field. Frequently, if we don't have adequate IV access, rather than put that in, we'll put a central anacortis in. But those are other options for fluid. You can give any kind of fluid, including blood products, through an intraosseous. Splinting is important for a few reasons. Think about a femur fracture. When the femur is fractured and the jagged edges of the bone become dislodged and dislocated, those those are now rubbing up against all the muscle that's around the thigh, for example. So all of the movement causes increased bleeding. It obviously causes pain. It can cause further injury. So we try to, in the pre-hospital setting, do as much splinting as we can. We don't spend time on the scene doing splinting absolutely everything. We try to immobilize that. Sometimes if a patient's on a backboard, just immobilizing their legs is good enough there because we want patients rapidly transported. There are several options. If we were in place, I would show you those. On the left here is the Sabre splint, which we have, but I have never seen used effectively. What you'll see in the ED most often is the hair traction splint. We get the leg out to length, and then there's a strap that goes right up in the hip here, right at the crease between the leg and the lower abdomen. There's two straps that go above the knee. There's two straps that go below the knee. And then there's a winch that puts a wrap around your foot and then brings you out to length. If you don't remember to put these, each of these have writing on it that says above knee, below knee, and by the ankle. Again, when we put these on, this is for demonstration purpose, but you should not have clothes on underneath. Frequently, when you put it on, the patient will get a lot of pain when you bring the leg out to length. But then once the leg's out to length, the pain gets much better. Two things to remember, and I always try to tell our team this when we're trying to bring someone out to length, is one, when the patient starts to complain of pain as you pull the leg out, don't let go because that'll increase the pain again. But sometimes the pain to reduce either a dislocation or a femur to get them reduced, once the pain goes away, remember the pain medicine's still around. So when you're giving sedation, whether you consider a conscious sedation because you're giving both a benzodiazepine and a pain medication, or whatever, the amount of pain medicine you give, now that the pain is reduced from immobilization, might be more than the patient needs. You've got to watch the patient's respiratory status after this is placed. Remember, usually after we get immobilized, where do we go next? We go to the CAT scanner. So what you don't want is someone who gets the CAT scanner and is really over-sedated and stops breathing or hypoventilating while they're in the CAT scanner. Pelvic fractures. Physical exam can be unreliable, but if the patient's awake and you gently press on the pelvis, they will get some pain. We don't want to rock the pelvis. We should have talked about pelvic rock, and we'd rock the pelvis back and forth. Well, if the pelvis is fractured, we've just increased the bleeding and the pain. So we try to avoid that. And again, we will log roll them, but we'll try to limit the amount of times we do that. We now have the pelvic binder. This is the SAM splint. These are the ones we have in our Lutherans ED. There's also one called the T-Pod. It comes in orange and a variety of different colors, but allows you to put it over here. It should be just below the anterior superior iliac spines. Again, you should not have clothes on underneath because as you put this on, it will fold the clothes on underneath and it will create pressure breakdown. So this is the SAM splint here. The beauty of it is it's got the directions. If you don't put this on often and forget how to do it, it's got directions to tighten this down. We usually try to get an x-ray before we put this on if it's not been applied in the field. And that way we can identify if it's truly an open book pelvic fracture that will require that. If we get one and find out it's an open book pelvic fracture, we put this on, we tighten it down, we'll repeat the x-ray to show that the pubic symphysis is up front, but that we've closed down the volume of the pelvis. Once again, the reason for this is there's a lot of pain in terms of moving a patient around with an unstable pelvic fracture. So you move them from the ambulance gurney to the hospital stretcher, from the hospital stretcher to the ICU stretcher. That can be pretty uncomfortable. We put this on, it actually controls the pain. It's a lot easier to move them around. So we need less pain medicine. The other thing is with the pelvis, which is in the extraperineal space, you can lose a lot of blood into the pelvic space. So binding it closes the potential space volume that you can bleed into. Some people try to take a hospital sheet and put this on and tie it around. I have never seen us successfully be able to close down the pelvis just by using a sheet and cranking it down. So the commercial devices work much better than the hospital sheets. These commercial devices are also designed so that you can do interventional radiology and get access to the femoral vessels if you're trying to see if there's any active extravasation that needs to be embolized. So how do we optimize pre-hospital resuscitation? We usually either use low volume IV fluids or no fluid at all for major trauma. We try to splint all fractures because, again, that reduces the bleeding. We try to dress all wounds, especially those wounds that are actively bleeding. Obviously, with a pelvic fracture, we'll use those and put the binder in if it meets protocol. Obviously, tourniquets are necessary. And then the one more thing is limiting scene time to 10 minutes. There's really nothing that needs to get done that takes longer than 10 minutes. Now, what we do with our pre-hospital providers, if they're on the scene longer than 10 minutes, we audit that. And so, for example, if the patient's entrapped in a motor vehicle, that's understandable. If there's a delay to get access to the patient for the scene safety reasons or law enforcement is involved, that's also understandable. But if someone's been hit by a car and is laying in the street, that shouldn't take more than 10 minutes to quickly get them immobilized and get them in the back of the ambulance. Many of these things, starting IVs, doing some of the splinting, can be done en route to the hospital. So once the pre-hospital team brings the patient in, presumably they've given us a call in advance. We've activated the trauma team, so we're down in the trauma bay. One thing I hope we'll implement at some point is trauma team training, which is similar to team steps and crew resource management. But as the trauma team assembles, optimally what we should be talking about is the patient that's coming in, making sure we've got equipment available and ready, and then preparing what specific roles of the team are. Just remember, if you can think of, since we're in Indiana, the Indianapolis 500, if your job is changing the back left tire when the car pulls into the pit stop, your job is back left tire. If you help with the front left tire, that may sound nice because you're feeling helpful, but that means the back left tire is getting left alone. So we try to identify specific tasks for each team member so everything can get done synchronously while all of this work is done and we can multitask. When we talk about team training, there's a bunch of different courses. I'll just highlight a few. The trauma evaluation and management is frequently given to medical students. The core courses would be the advanced trauma life support, which is given to physicians, nurse practitioners, and physician assistants. That course has been out since the late 70s. Piggybacked on that is the advanced trauma care course for nurses. That course is given at the same time. The nurses and physicians, they take the same lectures and then they break out and do different things, but it's a great way that's incorporated the team. Many of you here will see the trauma nurse care course that's put on by the Emergency Nurses Association. I think that's the one we predominantly give here. If you're in the rural setting, anyone online from our rural hospitals, there's a rural trauma team development course. This is a course designed specifically for smaller hospitals. The trauma nurse care course, the advanced trauma care for nurses course, the advanced trauma life support course, all require that you go somewhere to get the course. If you're at a small rural hospital, you can't send your team because you don't have a lot of extra staff. So if you send team to a course, that means there's fewer nurses and fewer team members in the ED. The rural trauma team development course takes the course to your hospital. So the course is given in your emergency department. They give some scenarios, and then they do mock trauma scenarios in your own emergency department, so you can kind of see how things work with your own facilities. Again, communication is important. We obviously want to pay attention to episodic events of hypotension. So even a single low blood pressure is important. I always, when I'm in the trauma bay, ask the paramedics what was the lowest blood pressure, not what was the most recent blood pressure. They may say, it was 60 over 20, but we got them mobilized and now it's 100 over 60, so things look better, but they may not be. Again, there's a lot of evidence that even a single low blood pressure signifies some significant internal injuries. So we talk about the physiologic criteria that cause trauma activations, the mechanism of injuries, and then interventions. So when the EMS team comes in, we like to give some demographic information, mechanism information, injuries identified, the vital signs, and then what interventions and how did the patient respond. We try to do that in an organized fashion. Obviously, we can't do this. It's a little bit different if the patient comes in with a blood pressure of 60 over 20. We have a lot less time to move, so we have to move and coordinate in a multitasking fashion. But otherwise, this is the information we like to get. So as I mentioned earlier, the CDC has guidelines for transport of a patient to either a trauma center or to a a higher level of care. Again, they use physiologic guidelines, which get you the highest level of care, mechanism of injury guidelines, which get you a highest level of care, and then mechanism of injury, which should send you to a trauma center, and then special patient considerations. If you recall, we had physiologic criteria with the ABCDEs in our highest level trauma activation here at Lutheran, and the mechanism were patients with spinal cord injuries or gunshot wounds to the head, torso, or proximal to the knees and elbows. Special considerations in patients would be elderly patients, those on anticoagulation, pediatric patients, pregnant patients, and in certain cases, a patient with transplants or other complicating medical comorbidities. Those would all give the pre-hospital team indications of where they should go. Is it the closest hospital, or is it the closest trauma center, which may be farther than the closest hospital? So we want to be situationally aware. This is really important. We want to be aware of the patient. We want to be aware as conditions change. So we want to make sure that if a patient comes in talking and then all of a sudden stops talking, that may not be because they're calm and relaxed. That may be because their neurologic status is deteriorating, perhaps from a head bleed. So we want to be able to quickly detect things. Obviously, we know what the patient is. As the team assembles, we want to make sure we have the required tools. If in our pre-hospital setting, we know that they have had a failed attempt at intubation, we want to make sure that all of our intubation tools are set up. We want to make sure that the rapid sequence intubation medications are ready to go. We want to make sure that the suction is on and ready to go before we actually need it. And we've got to set the environment in the room so we have everything ready as needed. So we want to detect something, quickly diagnose it. Patients making sounds, we quickly diagnose a compromised airway. We need suction, because we know that if we don't do that quickly, the patient's not going to do well. So most potentially preventable trauma deaths are related to either airway obstruction or hemorrhage. So that's why airway, with the A, we want to assess that rapidly. In most trauma settings, while we have the trauma team leader, there's someone else at the head of the bed who's going to manage the airway. If you're at a rural hospital, you may be doing all of these, and it's a little bit more challenging. From a hemorrhage point of view, obviously hemopneumothorax, or any bleeding in the chest, any bleeding in the abdomen or the retroperitoneum, and then intracranial hemorrhage. Now, intracranial hemorrhage, you will not bleed to death from that, but you will bleed to the point that you've got pressure on the brain and you get decompensation from a neurologic standpoint. So again, what we mentioned earlier, all trauma patients should get oxygen until you prove otherwise. That's with a pulse ox. You want to do a quick assessment on their respiratory status. All trauma patients are bleeding until we prove otherwise. We want to presume the worst until we prove the best. So we don't want to think everybody's stable until they're slowly bleeding spleen. Now their pressure drops. Now we get into a situation where there's a scramble to get to the operating room quickly. So we want to work quickly and expeditiously. So sometimes if a patient comes in, they're hemodynamically stable, they're awake and talking, we're trying to take care of their pain, we really want to evaluate the belly. That can be with a fast exam. That can also be with a CT scan if they're hemodynamically stable initially, to see if there's bleeding. But we really want to make sure we don't burn up the golden hour, as it were, on the front end of the evaluation. We want to be able to have some of that time to do some planning. For example, if a patient has a splenic injury that's actively bleeding, but they're hemodynamically stable, we can manage that with interventional radiology. If we burn through that time from a prolonged or unorganized resuscitation, and now they've dropped their pressure, now they need to go to the operating room to get their spleen out because they're unstable. So again, we want to expeditiously get through the resuscitation. We want to prove all patients have cervical injury until we prove otherwise. And there's a variety of things we'll do once they get to the hospital to evaluate that. We certainly don't want to miss a cervical spine injury and have someone with a neurologic compromise because we missed it. All unconscious trauma patients have a brain injury until proven otherwise. The corollary to that is alcohol and drugs are not protective against head injury. So sometimes, you'll get a report, there's a large amount of alcohol, the patient vomits and it smells like a brewery. The patient's kind of not as combative or not cooperative as, oh, they're just drunk. Well, we got to make sure they don't also have a brain injury. because it's not helpful to that patient if we presume they're drunk while their epidural hematoma is getting worse. This is all a proactive means of management as opposed to reactive. When we have hemodynamically unstable patients, we really need to consider early definitive airway for a few reasons. Number one, if the patient is awake and alert, their pressure's in the 80s, but they're talking, we go, oh, they're protecting the airway. All of a sudden, their pressure drops to 60, they vomit, and now they've aspirated, and now we're in trouble. And the patient really is going to suffer from an aspiration pneumonitis in addition to whatever else they have. We want to reduce the oxygen debt. So if the patient is hypotensive, they obviously need to improve their oxygen delivery. That happens at the course of increased respiratory rate, et cetera. So by actually intubating them, sometimes we can take the strain off the lungs and the heart as we're working up other issues. We can also optimize their oxygen delivery. Again, if they have a respiratory acidosis or alkalosis, we can correct that simply with intubation. And it allows the team to focus on other life-threatening injuries. If they've got large joint dislocations, shoulders, knees, pelvis, or hips or elbows, we can focus on that. But it allows us to focus on other life-threatening things, determining where sites of bleeding are, and then coming up with an operative plan or an ICU plan. So again, I'll say this again, all trauma patients need oxygen until proven otherwise. We don't want to wait until they get hypoxic before we start the oxygen, because by the time they get hypoxic, there's really a lot of oxygen debt that's going on. Again, all patients need bleeding until proven otherwise, or all patients are bleeding, I apologize. Again, we want to recognize trouble. So pre-hospital hypotension, even if they come normally, we want to evaluate this. We want to check the vitals. We want to quickly do a fast. We can send off an arterial blood gas to look at a base deficit to prevent patients from crumping in the CT scanner or somewhere else. The base deficit is more negative than -6. That's when we worry about signs of hypoperfusion. We can also get the lactate. Sometimes that's available on the iStat. Again, there's 5 areas of hemorrhage, and we look at those by anatomic site. I'm going to do these a little bit out of order to explain kind of why we do things in resuscitation. So down about 4 rows down, you'll see thoracic or pleural. A chest x-ray is a way to rapidly identify if you've got massive hemothorax in the right or left chest. It will also give us some early signs of whether there's a mediastinum that's abnormal that would make us worry about an aortic transection. So that's why I like to get the chest x-ray very early on in the resuscitation. In fact, as soon as the ambulance stretcher has been removed from the bay, I call for the x-ray to get them to come in. We need to multitask this, but again, it's a quick way to identify, to rule in or rule out massive bleeding in the thorax. If the patient's unstable or unconscious, we can also get a pelvic x-ray. Remember I said the pelvis is in the retroperineum or extraperitoneal space. So again, that's not going to get picked up on a fast exam. But again, a pelvis with a massive fracture will make us be able to determine if we need to put the binder on or if there's going to be some bleeding there. That's why you frequently see us get the chest and pelvis. Now, if the patient is hemodynamically stable and they have no tenderness to pelvic palpation, we sometimes will get the pelvis x-ray, especially if we know we're going to get a abdomen pelvis CT. But that's why we get those 2 tests. From an intraperitoneal bleeding point of view, the FAST is probably the best. It's a rapid test to get. It can be performed easily with the ultrasound, and the best part, it's repeatable. So if you get someone who's hypotensive and you scan their abdomen with the FAST and it's negative, we can wait a little bit, give them some fluid or blood products, and we can repeat the scan. And sometimes if the blood in the peritoneum was not enough to be picked up on the first scan, we can sometimes pick it up on the second scan. You'll see DPL or diagnostic peritoneal lavage. That was historically used. It's used much less now because of the ultrasound. However, there are rare occasions when it needs to be used. And again, a gross test is diagnostic. This would be for someone who's hypotensive. For some reason, we can't get good views with the FAST, but they're hypotensive and we can't take them to the CT scanner because of their instability. So we want to quickly get a determination of whether we need to go to the OR and do an exploratory laparotomy. Long bone fractures are also a site of bleeding. It's pretty easy. You can take your hands on the patient and you can palpate the femurs or the humerus and identify that. You can get x-rays if you want, but really clinical evaluation should be enough. External bleeding is important. What we also like to get important information from the paramedics is they'll tell us there was massive bleeding at the scene. Now, hard to tell whether that was 500 cc's or 1500 cc's, but usually when they say there was a large amount of blood at the scene, that's helpful for us. The other place external bleeding always happens, and we sometimes underappreciate it, is scalp lacerations. Remember, most scalp bleeding is arterial on both sides. One of the challenges is sometimes you'll get a Curl-X wrapped around the head. They've got the pads on the side of their head if they're on the collar. So I always like to reach my hand around to the back of the collar and see what's pooling on the backboard as you're doing that. Again, massive bleeding from the scalp needs to be addressed before we go to CT scan. So again, to us to say we've resuscitated the patient, we have to make sure that all tissues are adequately perfused and we've restored oxygenation to the tissue. So we direct our resuscitation measures at number one, most importantly, controlling the bleeding. This can occur in the trauma bay with the pelvic binder, as I said. It may occur in the operating room. It may occur in interventional radiology, and it can continue on up in the ICU. What endpoints do we look for? We want the patient to be normothermic. Cold patients, cold kills trauma patients. So we want them to be normothermic. We want to quickly evaluate them. And then once we've done a thorough evaluation, we want to put blankets on them. We want to prevent them from getting cold. Sometimes if they've been outside and they've lost temperature already, that's a problem. The other challenge with hypothermia in trauma patients is it makes your coagulation cascade dysfunctional. So your coagulation factors, when your temperature starts to drop, are less effective, and in cumulative, they're all less effective. That's not something that's picked up on a lab test because the lab warms the blood up before they run it through the machine. But again, hypothermic patients also become coagulopathic, and that's not treated with fresh frozen plasma. Now, if you become coagulopathic from factor deficiency, that's also what we want to restore that. I'll talk a little bit more about massive transfusion protocol and how we try to balance blood product resuscitation. And then again, you want the base deficit to clear. And that means you want it less negative than -6. But you also want to do that because you've resuscitated them, not because you've given 10 amps of bicarb and now the number looks okay. So base deficit, obviously, amount of fixed base required to correct your pH. It correlates with lactate. Difference between lactate and base deficit is the base deficit corrects faster. Lactate sometimes takes time because you've got to convert lactate to bicarb in the liver, and that can sometimes take a little bit of time. So we frequently or classically looked at endpoints of resuscitation being blood pressure, heart rate, your pulse pressure. In other words, as you're early in hemorrhage, your diastolic blood pressure will go up before your systolic pressure goes down, but your pulse pressure narrows. You want to know if the patient's mentating. If they come in and they're talking, that means they've got enough perfusion to perfuse the brain. We'd like to look at urine output. We put the Foley catheter in. We don't count what comes out initially, but we want to see on an ongoing basis that they're continuing to make good urine. We want to see the base deficit correct without the administration of bicarb or sodium bicarb. We want to see the serum lactate correct. Again, that takes a little bit longer than base deficit, so that's why base deficit's a much quicker thing. And we want to see what the serum pH is, which kind of augments our evaluation of the base deficit. So we talk about damage control resuscitation. It's an intervention we do to avoid irreversible triad of hypothermia, acidosis, and coagulopathy. Damage control resuscitation means we do only what needs to be done from a life-threatening standpoint. If you're up in the ICU, you'll note that sometimes we'll take a patient out of the operating room and they'll come up with the big vac dressing on. What that means is we go to the OR, we try to stop controllable hemorrhage. We try to avoid spillage from any holes in the bowel, the stomach, the colon, the small bowel. And sometimes when someone's really sick, we will staple the bowel and take out the damaged bowel, or we'll take a skin stapler and close the holes in the bowel. but we won't try to reanastomose them or put them back together. So if you're in the ICU, we'll come up, we'll say we want to warm up the patient, we want to further resuscitate him, and then decide to go back for a second look laparotomy. So you'll hear us say the bowel is not in continuity or the bowel is in discontinuity. That means that the bowel is not hooked up, which is also why we don't put anything down the nasogastric tube if you're up in the ICU, because it's not in continuity. What we'll try to do is we try to warm the patient. I like to come up with a goal. So we come up to the ICU, the patient, let's say, is 92 degrees. I'll say, I want the patient 96 degrees in the next 2 hours. And why do I say that? I want us to have a goal, because if we just say, hey, let's rewarm the patient, 10 hours later, they may be 92 or 93 degrees, and that really hasn't helped the patient. So we want to actively rewarm them. That means we turn the room up to the temperature as high as it goes. It will be uncomfortable for the nurses and docs and all the ancillary staff that are in the room, but we're trying to warm the patient. We put the bear hugger on. We try to use warm fluids when the fluids go in. We try to avoid, when we've warmed the room, opening, closing the door multiple times. So we try to actively and deliberatively warm the patient. With the acidosis, we'll get a blood gas. We may make adjustments to the ventilator. And then with the coagulopathy, that all goes to the massive transfusion protocol and the balanced blood products we try to administer. So again, if the base deficit is more negative than -6, we're concerned that the patient has ongoing hemorrhage. If we're in the operating room, usually if the base deficit is less than -8, if the blood loss is more than 1,500 cc's, or if they start getting cold, that's when we will terminate the operative procedure and go into damage control mode, where we'll put the vac on and we'll come upstairs and try to further resuscitate the patient. So in the ED and during the resuscitative phase, and again, frequently this resuscitative phase spans both the ED, and again, if they're this sick, they'll be up in the ICU. But we want to put direct pressure on all external bleeding. If you have a scalp wound, this is rapid suturing of scalp wounds. In my world, this means taking an O-nylon or an O-proline and whip stitching it like a baseball and tying it down. That stops the hemorrhage. It does not, it's not a final closure. It's not supposed to look pretty. It's supposed to be hemostatic. Again, we don't always have the luxury of locally anesthetizing with lidocaine, this whole thing, so it can be a little bit uncomfortable for the patient at times, but we're trying to stop the hemorrhage. And again, you can bleed to death from a scalp wound. So that's why we want to get that under control quickly. If we've got femur fractures, we either put the hair traction splint on, as you saw in the pictures earlier. Sometimes we'll put them in a posterior splint with the fiberglass. Now, why would we make a difference? The problem with the hair traction splint is when you go to get x-rays, the metal of the hair traction splint can get in the way. If you're trying to do a CT angio of the lower extremity, you can't do it with the hair traction. So sometimes we'll put the fiberglass splint on it because that allows us to get x-rays as needed for orthopedics. That allows us to get any CT angio available for the vascular surgeons. So that's what we'll do. With the pelvic binder, we'll put that on. If we subsequently identify that they have arterial hemorrhage in the pelvis, we'll get interventional radiology to try to embolize that as needed. And again, if we have a mangled extremity, we want to rapidly reduce that, bring it out to length, assess the vascular status of that, and then determine with orthopedics, with vascular, with plastic surgery, how we're going to manage the leg. And usually that's in a multi-stage process. Fluid resuscitation, again, we're trying to minimize crystalloid because crystalloid has no oxygen carrying capacity. It's got no clotting capacity. So over the years, and this started in 2003 during the wars in Afghanistan and Iraq, we've gone to a more balanced resuscitation. So we tried to do a one-to-one it's really one-to-one to one. So for every unit of packed cells, we try to give a unit of fresh frozen plasma. Usually if we get at least a 2-to-1, so for every 2 of red blood cells, we want to give at least 1 of plasma. So if you get 10 of packed cells, you really need to have gotten about 5 of plasma. We don't give all the packed cells before we give the plasma. As soon as we're starting to go, usually to the 2nd or 3rd unit of blood, we're adding plasma. There should also be an equivalent ratio to the platelets. Just remember, a unit of platelets is usually a 6-pack. So if we say we've given 1 platelet, it really counts as 6 units because it's pooled. We want to warm all fluids because we don't want to contribute to coagulopathy. If you've got the Belmont or the fluid warmer, you're better off from a heat transfer point of view to warm the crystalloid. If you can't warm both the blood and the crystalloid, warm the crystalloid because the crystalloid has a larger capacity to carry heat and transport heat. You can't, although you think the blood products are colder than the crystalloid, that is true, but you can't add heat carrying capacity to the blood products without causing problems with them. And again, moving quickly to definitive intervention. So this is being a purpose-driven resuscitation team so that we use as much, and we can talk about the golden hour at some point in the future, use as much as that early resuscitative phase to come up with an operative plan or an interventional radiology plan rather than kind of being on the front end waiting to get to the CT scanner to identify those injuries. So optimizing resuscitation across the continuum. Obviously, we need to get the operating room. We got to do that quickly. We want to rapidly expose the patient, which means getting into the abdomen frequently, evacuating the blood, and we usually just put packs in the abdomen. Once we put the packs in, we start to, in a systematic way, take the packs out and identify any bleeding. Most common source of bleeding in the abdomen would be the spleen, followed by the liver for hemorrhage. And we want to actively get those under control. We also want to control contamination. So if there's a hole from either a gunshot wound or blunt trauma to the stomach, the small bowel, or the colon, we want to rapidly control that. That can be with whip stitching. And again, that's not formal control. One fast way is we take a skin stapler and we staple as many of the holes as we can. We're trying to avoid gastric contents or colon contents, stool from spilling all over the abdomen, and then giving us problems with sepsis down the road. We also, again, the trauma triad of death is hypothermia, acidosis, and coagulopathy. We really want to avoid that. And again, this requires a lot of reassessment. So we get to the operating room. We want to do this quickly. We determine if we need to damage control them. Now we're going to go up to the ICU to further resuscitate them and warn them, and we got to plan that. If a patient hasn't had CT scans because they were unstable and we take them to the operating room, I personally believe that frequently we should get them up to the ICU, get them warmed and resuscitated, rather than take a cold, hypotensive, hypothermic patient to the CT scanner for a prolonged period of time. There's other things we can do in the meantime to get the resuscitation completed, and then we can plan to get them down to the CT scan. But again, once we get a patient who's been damage controlled up to the ICU, there's a lot of forward planning we have to do. So I usually like to write down on a list, what x-rays do we need? How quickly do we need to rewarm the patient? Do they need more blood products? Do we need to check labs? And try to organize a plan for, here's the plan going forward of what we want to get taken care of and what order should this happen. Again, in the ICU, if you notice, this white binder here is the trauma pelvic orthotic device, the TPOD. Some of them come in orange now. These original were white, but those get put on there. You'll see a dressing here. You'll see a JP drain here, and you'll see a stoma over here. So again, once we get up to the ICU, much of the resuscitation continues. Again, as we're getting labs, if we have a consistent acidosis, a lactate that doesn't get better or is getting worse, or a base deficit that is getting worse, that can be a sign of ongoing bleeding or inadequate resuscitation. So we want to keep our eye on that. Another thing we have to worry about is if there's not ongoing bleeding, or if we think they've been resuscitated adequately, do they have myocardial dysfunction? So that sometimes needs a bedside echo to see if the cardiac function is adequate. One quick side note, as I mentioned earlier, when we track lactates, lactated ringers as a fluid does not increase your lactic acidosis. I don't shy away from giving LR to try to resuscitate the patient. Normal saline, on the other hand, will give you a hyperchloremic metabolic acidosis. So you want to be careful about large volumes of normal saline. Now, why do we use one or the other? I think lactated ringers is probably the preferred solution. The one challenge you get with that is if you're giving blood products, at least in theory, the calcium in the lactated ringers could cause some clotting with the chelating agents in the packed red blood cells. So if we're giving blood products, we usually do that through a line that's getting normal saline. So interventions that need to decrease the need for blood transfusion. So we want to intervene early in the resuscitation to stop bleeding. That's the pelvic binder. That's immobilization of long bone fractures. That's rapid resuscitation and determination of whether they need interventional radiology or operative methods. And again, when we do that, we want to get to the OR quickly in a time-sensitive fashion. If patients in trauma, it does not matter that eventually we do the right thing. It matters that we do the right thing in the right sequence at the right time. So there comes a time, if you've got a ruptured spleen, where you can become unresuscitatable. So even ultimately going to the operating room, if you get into decompensated shock, even if we get your spleen out, you will not survive. That's why everything is time sensitive when we want to keep things moving along. There are some novel methods to stop bleeding in the operating room theater. Among those are sometimes we use a hybrid operating room where both interventional radiology can work while we're working in the operating room. And then again, interventional radiology, and I can't emphasize enough, correcting hypothermia, acidosis, and coagulopathy. So all unconscious patients have brain injury until proven otherwise. So the one thing I can't encourage enough is don't presume because someone's intoxicated that their behavior in the emergency department is related to alcohol. You really don't want to get caught with this. And having reviewed charts over 20 some odd years and getting transfers from outside hospitals at various trauma centers I've worked at, I've seen all too often the mistake of attributing mental status to alcohol only to find out they have a significant intracranial hemorrhage. So again, when we talk about goal-directed therapy, there's a couple categories of patients I really want to talk about. One is the high-risk patient. Elderly patients don't have the same reserve as a 20-year-old. So a 20-year-old can come in with internal injuries and can tolerate that for a long time. They're resilient. They've got adaptive mechanisms. Elderly patients, when they start to crash, they crash and they may not come back. This is what I get into the time-sensitive nature. They may not take hypotension or internal bleeding for a prolonged period of time. So elderly patients with the same injury mechanisms, let's say an 80-year-old or a 70-year-old versus a 20-year-old, their mortality when they come in the front door is higher just because of their age, their medical comorbidities. So we really have to work quickly on these patients. Pediatric patients, the same way. They'll stay stable until they crash, and when they crash, it's really hard to resuscitate them. There can be a lot of emotion about pediatric patients. They're crying. Anyone that has kids knows this is a challenge. You don't want to hurt them by putting an IV in them, yet if they crash and their blood pressure drops, sometimes it's impossible to get the IV in afterwards. So we really want to be proactive with kids, particularly because kids can't always, especially if they're younger, can't always verbalize what's bothering them, where their pain is, and what's causing trouble. Pregnant patients, likewise, we have 2 patients, and the problem is that while we can measure the blood pressure of the mother, we have no way of interpreting uterine blood flow, which will be impacting the baby. So we really want to get there early on the mother. We try to usually go with fluids earlier in a pregnant patient than we would in another patient. So this permissive hypotension that we sometimes tolerate in trauma patients, we really don't want to do in pregnant patients, because by the time the mother becomes hypotensive, she's been shunting blood from the uterus for a prolonged period of time, and we don't want to harm the baby. Anticoagulants, I think everybody now, when you get 65, you get put on an anticoagulant. That seems to be all around the country. So you'll find people on, it used to be Coumadin was the only thing we had to worry about. Now it's Coumadin, it's Xarelto, it's Eliquis, it's a whole number of the direct oral anticoagulants, it's the thrombin inhibitors. And now we have Plavix, and it used to just be Plavix and aspirin. Now there's probably 5 or 6 different kind of antiplatelets medications that are used. So in the pre-hospital setting, if the paramedics identify this, we usually are much more vigilant about activating those as a level 2 activation if they don't meet criteria for level 1, because those patients can have significant bleeding. The other anticoagulant that we sometimes forget about is the one, if you have someone who's on dialysis, frequently when they get dialysis, they get heparinized for the dialysis run. So if a patient's on dialysis, we really want to be thoughtful about that. And finally, beta blockers. A lot of people are also on beta blockers. And again, so a patient that's not tachycardic doesn't mean that they're not bleeding. It may be that the beta blocker is preventing them from getting a tachycardic response. Again, when we do CT scans for thoracic trauma, one thing you'll see, and I don't know if you can catch it here, but right here up on the front, this is the right side, this is the left side if you're not familiar with reading CT scans, but there's a pneumothorax on the right side here. This is not picked up on X-ray because the lung field goes all out laterally, so it's an anterior pneumothorax. So as we do more and more CT scans for trauma, we identify a greater number of pneumothoraces. We call those occult pneumothoraces when they're only seen on CT but not on the plain X-ray. What do we do about those? It depends. If someone is intubated and put on positive pressure, we really have a low index for putting a chest tube in there, because what you don't want to do is take this simple pneumothorax and make it a tension pneumothorax, as we'll talk about in the next lecture. And again, some of these occult pneumothoraces can be quite large, as long as there's lung field that goes out there. It's hard to pick up on the plain X-ray. Down here in the back, you'll see both pulmonary contusion and you'll also see some hemothorax. You've got hemothorax on both sides with pulmonary contusion. And I don't know how good you can see here, but there's a rib fracture right there. I don't know how good it shows up on your screens. So again, CT scan of the chest really helps us identify a lot of injuries, the occult pneumothoraces and rib fractures that we previously would not have identified on plain X-ray. So there's a routine X-ray here. We want to get this early. Again, I like to get it as the EMS team is rolling out. I like to see that X-ray machine rolling in. It's really valuable because it helps us identify for any pneumothorax on either side, any hemothorax, and it gets us to assess the mediastinum there. We can identify some significant injuries. The other thing I'd like to point out is, and we'll talk about in the thoracic lecture, but underneath the clavicles and the first and second rib lie all the great vessels. So if you get fractures in the upper thorax, ribs 1 or 2, or the clavicles, that's a real significant injury transmission to just overlying the great vessels. Again, we don't want to delay procedures for X-ray, which is why we have lead provided in the trauma bay, so that we can do things in a multitasking fashion. CT scan is used for hemodynamically, I bolded this for emphasis, stable patients, okay? It's a non-invasive procedure. While they're quicker because of the new helical scanners, they still take a while you try to set it up, and it takes at least 20 minutes. Some people call the CT scanner the tunnel of death. I call it the devil's playground. Bad things happen in the CT scanner to unstable patients. And when you have someone who codes or has some unstable catastrophe in the CT scanner, invariably when you look at the chart, you can have predicted it by looking at the vital signs or the way the patient was prior to going to scanner. So really, this should be reserved for stable patients only, just because a lot of unstable patients, it just takes too long and things can happen there that are untoward. And certainly there's a lot of things you can always identify without going to scanner with an unstable patient. Here, one of the benefits of getting the three-dimensional the CT scan with 3D recons is if you look on the screen right there, you've got rib fractures going all the way up there. Now, when they do these reconstructions, they're also able to make it easier for the higher ribs, they're able to remove the scapula from the reconstruction, so you only see the rib cage. That lets you know how many ribs are fractured. It lets you know if there's a flail segment. It also, now that we do rib plating, it helps us stage the procedure if we have to rib plate the patient. Again, consistent organization and clear-cut communication is really what we need for effective outcomes. We want to have clear roles and goals. In the pre-hospital setting, there's usually a lead paramedic or EMS provider who kind of sets the pace. And again, when it comes to the trauma bay, that'll be the team leader. That can either be the emergency department physician or the trauma surgeon, depending on who gets there. But again, they're organizing the team. They're kind of looking out for everything. They're setting the pace and making sure everyone has good situational awareness. Again, it does take a team to take care of trauma patients. Teams communicate. One thing which we will talk about more when we do trauma team training, is I am unable to read people's minds and people are unable to read my mind. So if I need something, I'll say it out loud. So for example, I'll say, hey, before we go to CT scanner, we're gonna need a Foley catheter. And it's good to hear because with a mask on, or if you're doing multiple things, you like to hear someone, I'll get that. Then you know someone's heard you and someone's planning that. Or before we go to CT, we need some more rocuronium, some fentanyl, and some Versed. It's good here. I'll get that. Or someone says, listen, I'll get that after I do the Foley. Now I know that I've given someone multiple tasks, and they're doing them in a certain order. So I can reprioritize those, but I know that someone heard me. Versus if I say we need this and there's silence, is that because someone's getting it or is that because no one's getting it? Again, two-way communication is important. In the airline industry, when air traffic control gives a plane instructions for final approach, and they say land on runway 22 left, when the pilot says confirm runway 22 left, that means everybody understands what they're doing. Because if the pilot heard 22 right and lands on 22 right, that's obviously catastrophic. So good communication is good. Teams that use research-based protocols, again, one of our future trauma grand rounds, I'd like to do team training, and just to talk about how the team interacts. If you've taken the ACLS course or if you just recertified in BLS, this is the same team training they talk about at I think it's chapter 1 or 2 of that course too. So every team has a defined leader. Let's say if I'm in the trauma bay, I'm the team leader, but the success of our team involves the input of everyone. So again, if people see something that doesn't look safe, end tidal CO2 is not being recorded, someone sees the saturations going down, the blood pressure cycles and now the blood pressure is low, someone needs to speak up about that. And again, that all defines the team. And I think when teams work like that, there's much more satisfaction and enjoyment with the team. Trauma centers do save lives. There's plenty of information about that. And the one thing that the team needs to succeed on is making sure that we reduce preventable death. And again, trauma patients don't come in with a list of injuries on their chest or on a piece of paper. We've got to identify those. So these are evolving situations. It takes a lot of set of eyes to take care of them. But again, trauma centers do save lives based on the function of the team. Is that the last slide? Does it not go off slides?
No, it stays there.
Okay, do we have time for any questions or?
Okay, if anybody has any questions, please feel free to either speak up on the presentation itself or put it in the comment section here, and we'll answer those. We have a few minutes until our next speaker starts. He starts at 2:30. This time is reserved for any kind of skills questions. So I know on the itinerary put the iGel versus the ET tube, so maybe doctor can speak to the differences. I know you reiterate, I guess, the benefits versus downsides of each, and also the specific process or what you do and when, timing wise, do you switch from an iGel to an ET tube when it comes in?
So I've just taken, this is the iGel. It looks like an LMA, but this is placed and then it's ventilated. This is placed down and then ventilated. It's not a secure, it's an airway. So it's usually a rescue airway if they can't put an endotracheal tube in the field. The problem with this, if the patient vomits, this is not a perfect seal, so they will aspirate. So when we come in and we hear that the iGel is in place, usually we take a few minutes before, if we're ventilating the patient well, we have a few minutes before we decide to put the endotracheal tube in. Some information I need to know is, why was the iGel placed? Did they go in? Was there a lot of trauma in the oropharynx? Was there, when they tried to pass, did they visualize the cords but couldn't pass the endotracheal tube through the cords or what? That information is sometimes helpful to decide, do we try to orotracheal intubate or do we just go right to a cricothyroidotomy or an emergency tracheostomy? So those are the kind of considerations we'll have. But we try not to travel outside of, once the patient comes in with an iGel, we try not to leave the trauma bay until we have a more secure airway. Just because, as you can look at this, there's no real good way to secure this to the patient. So if you move to the CT scanner and that just even moves a little out of place, they're no longer ventilating.